as, as a part of Wonka Women and Group. And today we are going to discuss a very important topic from India. And our presenter for today is Dr. Ratna. Ratna is a family physician. She's a trained family physician in DNB Family Medicine and also currently pursuing public health in Sweden. And she has had very interesting and significant practice in India, taking care of primary care predominantly. And one of the important reasons why we thought this topic is important is, as we all know, abortion has been in our world for many centuries. Earlier, there were lots of ways to go through the abortion. And in the last quite some time now, the government and the NGOs are trying to legalize it and trying to help women to go through the process safely, especially in scenarios where there is a need for abortion. And a lot of legislations are in place. Still, it has been shown that the prevalence of abortion in an unsafe practice is continuing and is one of the leading cause of maternal mortality. Over to you, Dr. Ratna. Please take over and start the session.
Hi, ma'am. Thank you. You did not mention in the introduction that I was also your student and you are my mentor in the family medicine group. So thank you. Thank you for this opportunity. So can I share the screen? Or you will share the screen, ma'am?
You shared the screen, Dr. Ratna, so it will be easier for you to do it.
It is not enabled, ma'am.
Dr. Gunjan, could you make Ratna as a co-host, please? Thank you.
Is the option available now, ma'am?
Yes, yes. Thank you.
Yes.
Are you able to see my screen?
Yes, Ratna.
Yeah. So yes, as Srividya ma'am said, that this is a very important topic. And amidst the chaos that is happening across the world in Europe and US, where their women are fighting for their abortion rights, and we will see what is happening in Indian scenario, the never-ending saga of maternal mortality and the never-ending conflicts of abortion in India. So my main agenda for today is to talk about what is unsafe abortion for 15 minutes, and then what is the prevalence, causes, consequences if unsafe abortion is done in 5 minutes, and how evolution of Medical Termination of Act, Medical Termination of Pregnancy Act has evolved in India for a couple of minutes, for 20 minutes, and then what is the future scope for this act in 5 minutes, and we'll open the forum for question answers in the last 15 minutes. So let's get started about defining what is unsafe abortion. So there are two components for this. First is that it is an abortion, and the second component is it is done in an unsafe method, which together becomes an unsafe abortion. So what is an abortion? That can happen spontaneously for the woman. The fetus can be not viable. There is no more fetal movements perceived, or there is no fetal heart rate. So that can happen spontaneously, or it can be induced by some medicines or by surgical procedures, or after a procedure, like if there is an amniocentesis done, the abortion can be induced because of the after that as a consequence. So any of these, be it a medical or surgically, whether it is self-induced, which happens in the first 12 weeks or later, any of these things are grouped as a abortion. And what is unsafe abortion is that any abortion that occurs when the pregnancy is terminated either in an unsafe method or unsafe environment or by untrained person. That is called as unsafe method. This is defined by the WHO. So what is unsafe method? What is unsafe environment means after the abortion is done, the post-abortion care is very important because so that the abortion does not end up in infection of the uterus nor the infection of the pelvic area. So, or the lady does not end up in bleeding. So all these have to be comprehensively taken care by the abortion care, which is called as a comprehensive abortion care, where the woman is given information about the abortion and about self-management also, and about the options available for management also, and post-abortion care also. When all these things are not there, then we have something called as the unsafe abortion. So what are the unsafe practices usually that is done in India? So this is one of the qualitative study that I saw, which mentioned about, which asked about women, like what are the methods you use to terminate your pregnancy? So there, some people say about herbal remedies. They use some kind of plants in the form of teas. So this is one famous article, drink me and abort your baby. So this is one of the article written by the medical professionals in US. So there is a type of herbal mixture which can be given to abort. Then we have second is to practice some dietary practices which have a high concentration of prostaglandins, which will induce uterine contractions and terminate the pregnancy. So commonly we all know about papaya and pineapples and dragon fruits, so which are used for this purposes. And thirdly, foreign body insertions into uterine cavity. So this is one case presentation. This was a case which was reported in the journal. So this woman, there were sticks inserted into the uterus to terminate the pregnancy, and intraoperatively they could see that the uterus was perforated because of the sticks. And then there are, other than, of course, even herb insertion into the uterine cavity is also foreign bodies, but I have categorized into separate one because it is quite significant, because there is a toxic plant which can be inserted. Yeah, this is a toxic plant, and its juice is like milky white in color, and this seed also can be inserted into the uterus, and the mixture of that milk and the seed together is inserted into the uterine cavity, which will induce painful contractions and terminate the baby. So this is one of the interview thing mentioned by, sorry. So this is in the qualitative interview, one lady told about how her abortion was terminated a couple of years ago. So my aunt took the feather of a hen and to one end tied the piece of the cloth which has been dipped into the calotropis latex. So that was the plant that I showed you. And it was kept inside. And after 2 hours, she had a severe pain, abdomen and back. And after another hour, she had bleeding and the whole product came out. And this happened 15 years ago. Unfortunately, these practices continue even today. It is not an old topic, and we also have this problem even today. So what are my experiences from my clinical practices? I would like to share 2 stories from my clinical experience, how I encountered unsafe abortions. So one is during my internship. Mind you, the pictures are not from the original patient that I saw. These are the compilations from other case studies, but I've kept it for the sake of visualization. So during my internship, during my OB-GYN postings, there was a woman who was brought by the family members. There was a woman who was brought by family members in unconscious state. When she arrived, there was no BP recorded. The pulse was not recorded. She was basically in shock. And on examination, in the history, they have not told anything. They may never mentioned about any of her last menstrual periods, nor her unsafe abortion methods or nothing. So mostly the history remains unsuspected. But our OB-GYN, why they brought for OB-GYN when the patient was unconscious instead of going to medical? That itself triggered some curiosity among OB-GYN residents. And then they did a provisional examination because she was having a very bad odor from her body. So on provisional examination, the gynae felt crepitus. And the moment she inserted a finger, there was very bad pungent odor. So then if at all, if she was hemodynamically stable and if at all a CT scan was done on her, this is how it would have appeared, where there is a shadow in front of the pelvic cavity and abdominal cavity. And later, if at all a surgery was done to her, this is how the uterus would have appeared. Uterus is bloated with gas and there is a blackish gangrene to the uterus. So basically, it was a gas gangrene of uterus after unsafe abortion. Unfortunately, this history of abortion is usually hidden reason they do not mention about it, but they come with a purulent or pungent odor per vaginal discharge, and even last menstrual periods will be normal because they don't reveal the history, and sometimes during pregnancy can also be negative because the baby is already partially killed and the HCG is not significant for us to detect that she is a possible pregnancy or possible abortion candidate. So the second case during my post-graduation, unfortunately, we lost that patient actually because she came in septic shock. They isolated her and gave the penicillin antibiotics, but we lost that patient in just a few hours, and she was bleeding because of the gangrene and also because of the septic shock, DIC, disseminated intravascular coagulation. So next case during my post-graduation was was a lady. She was about 50 years old. She came to the hospital saying that she had a purulent or foul-smelling discharge per vaginum. And when her vagina was examined, it was a stricture kind of. The cervix mouth was very stenotic and very bad. And a scan revealed some foreign body in the uterus, and the lady does not even remember that there is some foreign body in her body. And then she was taken up for exploration, and then hysterectomy was done because of a bad uterine strictures and because of the infection of the pelvic area. So hysterectomy was done for her. But this similarly in this case that I have put here, this girl also, her mother was a psychiatric patient, and she used to insert some foreign bodies into this girl's vaginal area. And a tube light starter was inserted in her body, and the girl was so small that she doesn't even remember that something happened in her childhood. And then over years, she had a problem with the foul-smelling vaginal discharge. And then the vaginal examination and scan revealed that there was a foreign body. So similarly, like my case. And why the foreign body was inserted in my patient was because she wanted to terminate her pregnancy, and they have inserted some foreign body. So forgotten foreign bodies is one way that I have seen. And a bad septic abortion, which was infected and came into a infection, is the second type of patient that I have seen. So what is the prevalence of unsafe abortions in India then? So what was the situation in 2004 is this poster in 2004 said that, you see, 10 women died due to unsafe pregnancies each day in 2004. And then time passed from 2004, now it is 2022. What has changed is just 8 women die each day. So there is just 2 women whom we are saving in the duration of 20 years. So nothing actually we have done for the sake of abortions, or nothing actually happened in saving these women, unfortunately. But what are the causes? Why people are having unsafe abortions, and what is the reason for this unsafe abortion? This is a beautiful picture which says that it is 47.6 times the abortion is indicated when the woman is having unplanned pregnancy. So this was an unwanted baby, and that's why they want to take it. And the rest, other causes are like there are
ये आउटडोर साइज छोटा है क्या वो?
yeah there are complications in mother. There are maternal complications, or the young child is too small, the less spacing is, so it is a not properly spaced pregnancy, or there are some health reasons for the mother, and there are some other reasons. But all of these are about 50%, but the bulk 50% is because of unplanned pregnancies. And why these unplanned pregnancies are? Actually, they are directly related to the unplanned or failure of the contraception, or improper knowledge about contraception. And who is performing? It's 54% of the time it is a doctor, and then the 25% is by herself, they are conducting abortions. So private sector is taking most of the burden, and public sector is about a quarter of the burden. And even the home by self, about 25% is happening in the homes only. So this is the current epidemiological profile of abortions. So who is preferring hospital and who is staying at home? Who is doing unsafe abortions at home? So if we see the profile of the women, we can see that who are coming to the hospitals, who are getting abortion under a medical care, are about women who are 20 to 30 years age group, and who are married, and who already have children, who have failed contraception, or who have a good socioeconomic background, and who are from mostly urban areas. But unsafe profiles are either too early pregnancy or too late pregnancy. They're kind of ashamed to reveal their pregnancy status, or they're not married, or they're separated, or are widowed, or illiterate, or rural women. So we can see that people who are suffering because of this unsafe abortions and whom we are losing are basically this profile of candidates. And we all know what are the consequences of unsafe abortions. That the consequences we all know is excessive bleeding or infections and or long-term consequences like a pelvic inflammation disease or trauma to the cervix, vagina, uterus, and abdominal organs, or stricture stenosis. So these all are, if the patient survives from that kind of sepsis during that infection period, then there can be a long-term sequel for these also. And this is the third largest cause for maternal mortality in India. So we are now starting with evolution of medical termination of pregnancy and what are the acts or legislations available in India. Now we know why there is a problem in US or why there is a problem in Europe, or what is happening is because it is a sensitive issue. It has religious implications, it has ethical implications, it has moral implications. So only when there is a common understanding between all of these, and there is a strong political will to get into this abortion act into a legal into legislation, there should be a mixture of all of these. So that is what happened in India actually in 1960s, when Indira Gandhi was in power, and India was having a problem of overpopulation, and we wanted to restrict the births. So that's when we had a very stringent rules of family planning, and we had like even my paid versions. Like if you get family planning surgery done, you get money, you get leave, you get maternity leave, you get financial benefits. So that is a time where India was very rigid on family planning, and that's when there was a politically there was a thing like we do not want so many children, we do not want so many people, and we have to restrain it, and almost of it there, we don't want unplanned babies on top of this. So we need to terminate these unplanned babies. So that was the political will. But what happened with the medical will? Medically, out of every abortions, out of every for every one birth, about 73 births are aborted in India at that time. Why so many abortions? Because of unplanned pregnancies, and all of them were done in a very unhygienic, unsafe manner, which was causing many maternal mortalities. So medical reasons were like, we have to control these unsafe abortions and we need to do something about this. And politically, we wanted to control the population. And when all of them came together, that was a time where we set up a Shantilal Shah committee in 1960s. And the committee asked, like, what is the problem in India about abortions? Does it require something? Should we make a legislation? So just give a report of what is happening. And Shantilal committee has given a report saying that this many abortions are conducted unsafe and we are losing so many mothers because of this. So it is better to legalize. So one day reported and they suggested to better legalize to reduce the unsafe abortions. That's when the Medical Termination of Pregnancy Act was executed, and it was started implementing in 1971. So the act has specifications, but it was not a very liberal law. It legalized abortion. So if a woman wanted to get abortion, where can it be done? Who can do it? And what is the procedure that should be done? So there are limitations for this. This is what the act was all about. So where the MTP can be done, it can be done in a public hospital or any private hospital which is approved by the government. And who can do it? It is by any registered practitioner can do it. Any registered medical practitioner could do it. And who are the beneficiaries? A mother whose health is at risk because of the continuing pregnancy, or if the baby is born and the baby is likely to suffer very serious problems because of disability or mental disorders or whatever. So in such cases, such babies and such mothers are the beneficiaries. Or if the pregnancy happened because of a rape or a sexual abuse, or married couple and they have taken contraception but it failed and this was an unplanned pregnancy, in such cases they could terminate the baby legally. So until what gestational age? This was not a medical recommendation, a medical cutoff or whatever, but it was understanding between all of them, and they agreed that until 12 weeks of gestation, we could do this medical termination of pregnancy, and up to 20 weeks in certain cases. Until 12 weeks is for all, but until 20 weeks for certain cases. And how it can be done? It was mostly surgical practices by vacuum aspiration and such. The then available techniques, whatever were there, they could use those in the hospitals. And it was the consent of the person that is needed, or if the mother is mentally unwell or unfit for the consent, or if the child it's a minor, then it is the consent of the guardian who has to give the consent. And what if there is a violation of this act? So I am a medical practitioner and I terminate a pregnancy beyond 20 weeks. So what happens to me? For a medical practitioner, there was no legal proceedings. But if there is a willful violation, then the fine was up to 1,000 rupees. Willful violation means it's by the patient, or like I'm a woman and I want my pregnancy to be terminated, and I went to a hospital which is not licensed. Then I or the hospital will have to pay 1,000 rupees. But the doctor was not liable for any complications for the sake of good faith. This is what happened in the first MTP Act was released in 1971. Over a period of 20 years, what happened? 1971 onwards, about 1,800 institutes were there, public institutes, which were approved for abortions, and about 3 lakh abortions were conducted in the hospital settings. Over years, over 20 years, 1900s, the number of facilities which have license to do medical termination increased by 6 times, but the abortions have only increased double, like 3,81,000, now it's 5,86,000. So there are still unmet needs, and there are many more abortions happening outside which are not coming to the hospitals. So this was a problem. And also the problem was that now before the act, abortions all were done in an unhygienic way by untrained person. But after the act, what happened was there are many frauds happened because it opened for private sector also. And women now were undergoing unsafe abortions in ill-maintained hospitals, and the hospitals are not maintaining hygienic standards, or they did not have a proper abortion protocols. And now unsafe abortions were more even in the private sector, and not up to the standards in public sector. Over time, we had to adopt to the new changes also, and we had to address these legislations also. So there was a evolution, and there was an amendment for this MTP Act in 2002. In 2000, US approved the medical method of medical abortion, like mifepristone and misoprostol. These were approved in 2000. And in 2002, our MTP Act was amended. What it incorporated? It incorporated the techniques of abortion, not just the surgical methods, but up to 7 weeks. If you want to terminate, you can also use a medical method of termination. And it added some more strict rules. That is, the private sector which is conducting abortion, strict hygienic regulations and mandatory necessary equipments like ventilators or methods to manage the complications. The hospital should be equipped to manage the complications. So there were a list of gadgets that you should have all the sterile OT, surgical OT. You should have all this if you want to conduct a abortion in your healthcare setup. And then who can do it also? They did not want the general practitioners or registered medical practitioners in general. They wanted specifically those people who have training in OBG or who have conducted medical termination in pregnancy, like at least to assisted 25 medical terminations in their past experience, or they have 1 year experience in OBG department, or such some experience they have warranted to cut down these unsafe abortions in bad environments in the hospitals. And also, violation rules have become more strict now, that if there is any willful violation. So now you see the gestational age is 20 weeks. So if I'm a registered OBG practitioner and I try to abort a child which is 24 weeks, then I am eligible for a violation. I become a violation to MTP Act, and I can have a punishment of 2 to 7 years of imprisonment also. So that was the stringent rule they made, so that the Abortion Act is not misused by people, or it's not conducted in unsafe, unlicensed places. And later, a few more decades passed on, and what happened was that there were some special cases. Like this was a case which has actually shaken the attention of medical field again in 2008. She's Mrs. Nikita Mehta. What happened is she was 24 weeks, 25 weeks pregnant, and her anomaly scan showed that she had a congenital heart defect in her baby. And then she personally chose that she does not want to raise this child because of the abnormality, and she requested for an abortion. But until then, our act mentioned like you can abort only until 20 weeks. And she was 25 weeks already. And then she had to approach the court that she wanted to terminate the pregnancy. But the court refused her plea, but she had automatically had miscarriage after a week after her judgment, and she lost her baby anyway. But this actually case has triggered some discussion in the legal field about if the child is disabled, then even if it is beyond 20 weeks, you should consider giving relaxations for such babies. But what was the trigger that happened is on the counter, it was like, okay, so if the child has disability, that means the child has no right to live. So are we curtailing the rights of disability? So this was the problem that happened. But that is one scenario. And the second one was, this is a 14-year-old girl from Gujarat, and she was raped by a medical practitioner when she went for a sickness into the hospital, and then she doesn't even know that she was sexually abused, and she had missed her periods, and then when she was taken to the hospital, then she was knowing that already she is 20 weeks pregnant and beyond. And then they wanted to terminate the pregnancy because she was now considered as a rape victim. But court denied her because it was beyond 20 weeks of gestation. And several such cases have moved the Supreme Court. And then and a few other cases were like marital rapes. She is a married woman, but she is forced by her husband. She doesn't want the baby, but the unplanned pregnancy happened because of a marital rape case. So such cases actually triggered for changes in and relaxations of the new legislation, which amendments have been recently happened, and the amendment is 2021 amendment happened. So what actually happened is we included more beneficiaries. So you can do termination not just for 20 weeks, but even until 24 weeks if the victim is a rape victim, or if there is a fetal anomaly beyond 24 weeks also, you could do termination irrespective of the gestational age. Now, even 30 weeks gestation, if the child is having a congenital anomaly, the mother can approach the medical practitioner and she can terminate her pregnancy if the fetal anomalies are substantial. So these we added more beneficiaries, and also unmarried women. The problem was like, if it, not just married women, unmarried women also have similar rights of abortion. So that happened. These beneficiaries also included, and there was no need to prove that after a marriage that your contraception was failed, and there was no need to get the consent of the husband to get your MTP done. So these are the amendments that happened in the 2021, and including the medical practitioners, the medical methods of termination until 7 weeks. But strictly the criteria still remains that the MTP can be done only by the medical practitioners who have OB-GYN experiences, or who have terminated 25 in the past, and so on and so forth. So we'll come to a conclusion of what all happened, the evolution of MTP. First was a Shantilal committee was set up, and then after the Shantilal committee came in, the MTP became a legislation. And then in 2002, once the mifepristone, misoprostol was in the market, we added that into the medical termination of pregnancy. And then after that, now we included more women for beneficiaries into this category, including unmarried or fetal anomalies or rape victims. Now it is very liberal rules now. And we came out from the intention was initially for unsafe abortions and for preventing maternal mortality, and we have slowly evolved into it is a right of a woman, reproductive right of a woman. So we have evolved to this stage where we now say that abortion is a reproductive right of the woman. And I want to just clarify one thing, that this has nothing to do with the PNDT Act. PNDT means prenatal sex determination. So if the sex is determined and then the mother wants the baby to be terminated because it is a female baby. So that act is totally different from this act in this medical termination. And anyway, because we are now no longer detecting the gender of the baby, both acts are independent. They are not mutually related to each other. Their agendas are different. So now, despite of so many reforms, why Indian women are still seeking unsafe abortions? And the latest statistics that I showed you was about 8 women are dying because of unsafe abortions each day. So why this is happening? I want to show you, I can say this is a kind of qualitative study done on streets by a journalist. So she is asking about abortion rules in India. It's interesting. It will take just 2 minutes. It just takes 2 to 3 minutes. So let us just see what is the attitude of abortion in India.
And I'm here on the streets of Connaught Place. And hi everyone, my name is Asmita, and I'm here on the streets of Connaught Place in Delhi to talk about abortion. Abortion हमारे देश में लीगल है कि नहीं आपको पता है? लीगल नहीं है. पता. Yes, of course, the abortions are legal and no, maybe legal. Allowed hai? Allowed hai? Actually, abortion is legal in India up to 20 weeks under the Medical Termination of Pregnancy Act. According to the Act, women can legally avail an abortion if the continuation of the pregnancy is found to seriously impact the physical or the mental health of the woman, or if the fetus is found to have serious mental or physical disabilities. Yes, legal. Yes? MTP Act. आपको क्या लगता है कि abortion legal होना चाहिए कि होना चाहिए? होना चाहिए. और क्या? It should be legal to abort. क्योंकि बच्चों के भविष्य का 2 बच्चे रहे, 1 बच्चे रहे तो सही से बेहतर परवरिश हो सकता है. ज्यादा बच्चा हो तो कहाँ से हो पाएगा? महंगाई भी तो ज्यादा है. बिल्कुल नहीं होना चाहिए. मेरे ख्याल से नहीं होना चाहिए, अदरवाइज इसका मिसयूज होना चाहिए. मिसयूज के कोई भी कर सकता है. आप सपोज अगर कोई लिविंग रिलेशन में रह रहे हैं या क्या है, वहाँ पर कुछ ऐसी पोजीशन क्रिएट होती है तो वो सब कुछ अच्छा. Right of every woman like who doesn't have sex, we can have sex, and it's okay if they are getting into pregnancies and all. The laws should be even more liberal and also more respectful towards women. लीगल तो मैडम होना चाहिए, लेकिन वही वाली बात आती है कि सर्कमस्टेंसेस के ऊपर है. In some situations which are exceptions, it can be accepted. It was abnormal child. हाँ. या प्रीमेच्योर डिलीवरी हो रही है और उसके इसमें लगता है कि भाई जो उसकी मदर है उसके लिए क्रिटिकल पोजीशन है, तो उसके इसमें तो जरूरी हो जाता है कि कराना ही पड़ेगा. ऐसे किसी को मतलब मारना ठीक नहीं है ना. Killing a life and that is also not nice. But हत्या ही कर रहे हैं तो. One second, quick question. When you're buying a ticket for a pregnant woman on the bus, you buy 1 ticket or 2? The fetus isn't a person, and abortion isn't murder. As long as the fetus exists within the woman's body, it is still her body and her choice. Should married women in India be allowed to have abortion? She should, but in India, it's, I guess, totally depend on the family. She should be allowed to abort this child. नहीं चाहिए तो उसकी मर्जी है, करा सकते हैं. She can go against it. Maybe she doesn't want his child. I don't think married women should be allowed to abort. बाद में ये सब प्रॉब्लम क्रिएट हो जाती है. कल को आपको तो डायवर्सिटी का बच्चे का क्या होगा? इसलिए तो अबॉर्शन पूछ रहे हैं ना. इसीलिए अबॉर्शन करवाना चाहिए. नहीं करवाना चाहिए. पहले से इतने प्रिकॉशन लेके चले कि प्रिकॉशंस आर बेटर देन क्योर. लेकिन इससे पहले प्रिकॉशंस ले लो. ये प्रिकॉशन क्या है भाई? Nobody wants an unplanned pregnancy. Maybe that's why it's called unplanned. But the fact of the matter is that unplanned pregnancies can and do happen. Instead of shaming people who had them, don't you think we should just make it easier for people to deal with it? Should unmarried women in India be allowed to have abortions? Should be allowed to. She should also be allowed to go for an abortion. Definitely, she don't want to have the child. If she wants to have the child, her choice. But if she don't want to have a child, no, it's okay. ये तो गलत बात है. अच्छा, क्यों? अब ये तो गलत ही है. Totally depend on the woman's choice that she want to carry or not. नहीं होना चाहिए क्योंकि आजकल तो सब अपनी मर्जी से अगर आप किसी रिलेशन में हो तो ऑलरेडी आप अपनी रिलेशन में हो और आप इस चीज को कर रहे हो आगे बढ़ाइए रिस्पांसिबल हो. और अगर इसका मतलब आप जो कुछ कर रहे हो फन के लिए कर रहे हो, एंजॉयमेंट के लिए कर रहे हो, Nothing else.
Deserves an abortion and who doesn't is a slippery slope. Everyone deserves a right to a safe abortion. It's very tough for the women who are not married who go to hospitals and they have to face even ridiculous doctors there, I would say, because they need your husband's consent.
I think that the partner or the parents' consent is necessary to get an abortion.
Legally, of course, husband's consent is very important.
She should be the one to, sign, and it shouldn't be the husband.
According to the MTP Act, the woman does not need the consent of either her partner or her parents to get an abortion.
Because it's a private life, and no one should interfere actually. And if the society and people are interfering, then it's their mistake, not ours.
People are very emotional about abortion, pregnancies and all. I don't think so. It's that an emotional kind of a thing. Of course, yes, you have a baby inside you, but you can't feel anything before 5 months or 6 months. I'm practical about things, but there are a lot of more different things. Baby ho jana doesn't only mean that you're a mother. Why so much abortion stigma? Abortion is a super straightforward medical procedure and it happens much more often than you think. 26 to 41% of all pregnancies end in abortion. And in India, even though abortion is legal, 67%, that's 2/3 of all the abortions that take place, happen under unsafe and shady conditions. When we shame women who are seeking abortions, we lead to abortion stigma. When we stigmatize abortions, we're not reducing the number of abortions, only the number of safe ones. Abortion stigma puts women's health at risk. Abortion, mera haq.
So this is a kind of qualitative interview, I can say, although this does not represent the entire Indian scenario, but more or less this is what the studies also show, that people are not aware that MTP is legal in India, and people think that MTP can be easily misused, and they, under the assumption that it's not legal, they recommend it should not become legal, but it is already a legal thing. And they equate killing a baby is a murder, and decisions on the abortions depend upon family members' opinions, and precautions, a failure of contraceptions, precautions are not given properly, and that is why there is a problem with abortion. So that should be taken care. And shame in the society for unplanned pregnancy, even for a married woman and also for unmarried women. And if unmarried woman gets pregnant, it is entirely her responsibility. And unmarried women get ridiculed by the society, and consent from the husband and partner is all mandatory for abortion. So these are the things actually which are the barriers for women in seeking a safe abortion. So as I mentioned, it's not that abortions are not happening in India. They are anyway happening, but all of them are happening in very unsafe method. So it should, the awareness and the stigma reduction is going to help women to actually seek the safer methods of termination. So abortion stigma is the reason why women are still seeking unsafe methods. So what actually India needs then? First thing is that the number of people who are eligible to give medically safe methods of abortions are less, because they are only restricting for OBG practitioners. If it is open for qualified general practitioners, for trained family physicians, then there are more people to cater services. Because obstetrics and gynae people are mostly located in urban areas and not much in rural areas, but our population is mostly located in rurals. So a trained family physician who is usually spread across all places, not necessarily urban, they can bridge the gap, and they can give more safe abortion services in the rural areas also. And this is a recommendation that you can also involve nurses and other midwives who are trained. They can also provide medical abortion services, that is using the tablets and pills and how to monitor. They should be given training, and they can also be utilized. And regulating the private sector and streamlining their methods, because that is a place where we are having now mostly unlicensed practices or unsafe environment is there in private sector. And improving the public sector in terms of stigma, in terms of quality, and in terms of training and counseling services also. So public sector should improve in their services. And also utilizing the latest telemedicine facilities, so that our urban practitioner also can cater services to a person sitting in the rural area, instead of relocation to that place. we can better utilize the technology and help this through the telemedicine, help bridge the gap and make it a safe abortion practices in India. So this is the booklet that we have by Federation of Obstetrics and Gynae Services, FOGSI, and this organization will keep publishing the latest updates on MTP. So this is about 150 pages book. So anybody wants to know more about the latest updates can read this booklet. So that's it from my end, and thank you for patient hearing. And if you have anything, the floor is open for questions now.
Thank you, Dr. Ratna. You have done a very comprehensive research on abortion and its practices done in our country. And it was quite interesting to see how the legislation has evolved over a period of time, catering the needs of the change in the society and how things have evolved in the last 50 years and what are the requirements. I understand there is still a long way to go. There are still areas of improvement. I completely agree with your recommendation in the last slide, which is more family physicians being part of it, especially in the first 12 weeks. We could definitely contribute in providing a safe practice. And I think this was also discussed in our group as well, right? In our family physician groups. And one of the interesting point is we were planning for the session and this discussion was going through. And one
Yes.
student family physician was asking about it. And there were a lot of uncertainties among the practitioners about who can do it. Are we as a family physician, can we do it? Is there a legal requirement? Should we get a sign from the consent from the partner or the husband before we go ahead and do it? And I'm sure there were quite a few. Ratna? The floor is open for question. Anybody would like to take any questions on this regarding this topic? Dr. Swapna has a question. Welcome, Dr. Swapna. Good to see you today. Your student is presenting. I'm sure you must be really happy.
Hi, ma'am. Ma'am,
Dr.
you're in
Swapna,
mute.
you're on mute. You're on mute. Yes.
Sorry, it's audible now?
Yes,
Yes.
good to see you.
Okay, hi, nice meeting you. I had to, sorry, I got a bit late. Just my point was I was giving mifepristone with misoprostol as the first, at least up to the first, I think it's 8 or 9 weeks, isn't it? So isn't that legal in India, Ratna, or is there any rules against that use of
Misoprostol is not a
mifepristone?
problem, ma'am. That can be given, but who is giving is the concern now. Until 7 weeks, any registered practitioner who have experience in OB-GYN or who have experience in terminating the medical terminations or who have a backup in managing abortions can manage. Like if you are prescribing MTP pills sitting in a hospital, then that's not a problem. Although you are a GP, you are working in the hospital and you have a backup to handle a complication. But if you are giving it from your own clinic without any backup, then that will become an illegal thing. So, so that is why to make it very easier, it is better for now. They have not giving any licenses for any practitioners. So if you in a clinic, it is not allowed. In a hospital, yes.
Okay. Yeah, I just want to give my thought about, because in Australia there is a training program for GPs, and we can attend. It's just online training with some questions you have to, answer that, and you are legally, prescribed. You can legally prescribe this mifepristone with misoprostol up to 9 weeks, and
Okay.
it's pretty okay. So most of us deal with that in our clinics itself. And there is a proper backup. There is I'm sure Vidya also must be knowing that. I don't know how it is in UK, but here it is very, very clear that up to 9 weeks GPs can do, because otherwise the hospital system is going to be clogged.
Yeah. The problem is that in India, we have many people who practice, and once the floor is open, then many more can practice in unsafe method. And then that is a lesson that was actually learned. In first MTP 1971, it opened for any medical practitioner was eligible to give. But what happened is, although they were medical practitioners, they did not have a good backup system and they did not have a good environment to conduct MTPs. And then the mortalities were stable because of these unsafe environments in the hospitals. So that's when they restricted that you should have this mandatory equipment, otherwise you are not licensed to practice, or you should have a training in OBG, otherwise you cannot practice abortions in your place. So that is why that rule has come, and it is still sticking there. But there is whatever I saw was that there is still the research is about telemedicine services, because even in public sector now in India we have telemedicine services. So they want to incorporate through telemedicine's MTP services also, and soon it can come. As the times are changing, the act will also get amended to adapt to the local needs.
Hopefully. I think we should probably write to Foxy also that, they should train family physicians at least, up to 8 weeks, up to 9 weeks, isn't it? It's a good idea to collaborate with Foxy.
Yeah,
Definitely.
I think
I
they
think
can
that
take it
would definitely make a difference, because that will help us to provide more services for women in need. And that is something we could take it up and take it from there. Dr. Nazira had a valid point. Different countries have different laws. Would you like to talk about it, Dr. Nazira? Given prescription can be misused. That's interesting.
Yeah. One prescription, then any other person also can use it, no? Their neighbors or colleagues.
Yes, that's unfortunate, but yes, that's commonly done.
And now even that another problem in India is that over the counter also they dispense in pharmacies, the MTP tablets. Without any prescription also it will be dispensed.
Correct. Our president, Dr. Elizabeth Reggie, is here today with us. Thank you, ma'am, for joining. Would you like to add few points?
Good afternoon, everyone. It was very interesting to hear about the abortions, the evolution, because it started when I was trained in India. Before that, we didn't have abortions. I agree with you, but like in South Africa, we do have different laws. Up to 12 weeks, where a trained nurse, midwife can actually conduct abortions. But then, can you hear me?
Yes, ma'am. We can hear you, ma'am.
Yeah. Okay. She can conduct abortions under the supervision of a medical practitioner. It doesn't need to be a family physician, because in rural areas we do not have family physicians. Family medicine is a new field in South Africa. We are still developing it. So we have medical practitioners who are trained in obstetrics, or who have an experience in obstetrics, who can guide the nurses. So before they do abortions, they would send the patients for sonar. So that means the medical practitioner has already seen the patient and confirmed that it's not an ectopic. They can abort the patient. Now that's one thing. Then another thing we have is that abortions can be done from 12 years, because a girl has the right to come and request for an abortion at the age of 12. That's a child right, that's child law in South Africa, that the child can come and ask for termination at 12 years. Meanwhile, for a medical consultation, she can only allow that at 14 years. But for abortions, it's 12 years. So that's a difference between India and South Africa and India, you have to be 18. Here it's 12. Then from 12 to 20 weeks, a medical doctor can conduct abortions on the grounds that you have said, rape, child being abnormal, or the mother is mentally ill, or some other medical illnesses. But from 20 to 24 weeks, it should be two practitioners. One should be an obstetrician who gives concern that this abortion can be done, and that's on a medical grounds. So each country has different rules, and we do send our family medicine registrars to the abortion clinic to get training and to conduct abortions during their training practice, so that they are experienced while they come out to conduct those kind of abortions. So there are differences, and it should, as a senior lecturer, I would advise that it should be a requirement for all family physicians to be trained on abortions. Yes, there are family physicians who says it's my right not to do abortion, but they have to guide the patient to a safe environment, or to a medical officer who can conduct those abortions. So we also protect the right of the doctor if he or she doesn't want to conduct the abortion. We have herbs, just like you said, but we do have terrible instruments inserted. Like you can see, a hanger can be used to abort babies. We have removed hangers, we have removed instruments from patients. In my practice, I have removed hangers from, and then at the end we have to, we don't have patients who come at the last minute. They actually come and they start bleeding, because now they don't know what to do, and then you will have to ask. And then we have the traditional doctors who would insert misoprostrates like 4 or 5, and then the patient can go into shock, and we will have to take that as a. So normally our emergency, it comes to our emergency unit, because obstetrics, no, not obstetrics, it's gynecology is seen, gynecology obstetrics sees patients only after 24 weeks. So anyone that is before 24 weeks comes to the casualty or emergency unit. So we see most of these cases in the emergency unit. Even in South Africa, it's a high rate. Like you see, in most of the developing countries, 97% of the abortions is unwanted pregnancy, and mainly they come to seek help when they are bleeding or in shock, or they do not know what to do. Here, awareness has been given through community health workers, which have just started in the past 5 years. You can use your Anganwadis, because it's similar to community health workers. They can actually start giving health educations to young generation, and to the mothers who are sitting at home, to know that this kind of things are not good and you need to make changes around it. But thanks for this information. It's almost similar everywhere. But the policies and the policymakers have to make rules and regulations based on problems that are rising in India. Because like recently, a homeopath, husband and wife, did something on on a lady, if I'm not wrong, did cesarean section or something, and the patient died in India. So you see, there are people who take chances, who think they can do because they're medical doctors, but medical doctor in a different field, they can't, they forget they have limitations in their practice. But for a family physician, I think it's one of the things that we can do and help. Because the population is high, we are more in the rural areas, we can help patients. Thank you for this opportunity.
Thank you, ma'am. Thank you for sharing. Dr. Hina, you want to add some points?
Hi, thank you very much. Sorry, I was on a run to get another car. I rent a car when I come to the UK, so they wanted a replacement. It was amazing. I've taken some screenshots, which I'll share, but I think you've touched upon a very difficult topic in the most professional way possible, keeping in mind our cultural context as well. So hats off to the team. And I think we need to make this topic talkable in the society. And there is no better cadre than primary care physicians. So we need to be confident under our skin to be able to talk about it, not only with the patients, but also with the society to generate awareness. So thank you for doing that.
Thank you. I think we have come to our end of our session today. And this is definitely one of the very important session for all of us to understand the problem. We are aware of the situation in our countries. It's how we as a family physician can take it further and help our patient in this process. And thank you, Ratna, and you did a great job in picking up so many important information, and thank you so much.
Thank you for this opportunity. It was nice to see my teachers and senior faculty members here.
Great. Thank you all. Have a good
Thank
evening.
you.
And,
Okay. Bye.
yes, bye-bye. Thank you, Gunjan, for helping us out.
Yeah, welcome, ma'am, and would like to really thank Dr. Ratna. This was such a wonderful presentation. And along with that video where everybody was putting in their opinion about what MTP rules are there, that elaborate video, everybody's interview was really nice stuff.
Great. Thank you. Bye-bye all.
Bye. Happy weekend. Bye.